when you talk about targeted therapies in lung cancer, you're opening up a Pandora's box, because we know that a huge number of lung cancer patients have potentially actionable mutations. And we now know huge amounts of, and a lot of data coming out about response rates and progression-free survival rates on a range of different targeted agents. I think that, and this is changing rapidly all the time. The really big news from the current ASCO was adjuvant TKI use in EGFR mutation positive patients. This is a very difficult area, because people need to have a sense of what they think adjuvant means. So for some oncologists, I'm probably in that group, an adjuvant therapy for me is a therapy that results in an increase in survival. So you have a curative procedure, surgery, in this case for an early lung cancer, and an adjuvant therapy needs to be associated with increasing the cure rate of that original definitive curative procedure. So adjuvant breast cancer treatment improves the cure rate for breast cancer. Adjuvant colon cancer treatment improves the cure rate for colon cancer, and so on and so forth. So we know that in the EGFR space, in advanced disease, the TKIs are highly active. And in the adjuvant space, we've had a lot of debate about whether these drugs work or don't work. Two key studies at ASCO, the ADAURA trial is looking at adjuvant osimertinib. So osimertinib is the first-line gold standard TKI of choice based on the FLAURA trial, now being tested in the adjuvant setting. So these are resected patients with stage 1B to stage 3 cancer, and they are given their standard chemo, but the randomization is to adjuvant osimertinib or no adjuvant osimertinib. And what you really see is a striking, really quite profound difference in disease-free survival. Median disease-free survival in the resected group who didn't get adjuvant osimertinib was 20 months, and in the people on osimertinib, it hasn't even been reached, and the curves separate massively. The question is, will that translate into an overall survival benefit? And the other question is, does it need to result in an overall survival benefit for a doctor to give it to a patient? And I think now, based on the conversations I have with my peers and colleagues across the country and even across the world, actually, on social media, is people have very widely differing views on this, with some people feel that the data just isn't good enough to be used, and in its current state we need overall survival. By the way, that trial's primary endpoint is disease-free survival, it's not overall survival. And so there is this big debate going on in the community about the importance of this data and how it's applicable. And I think, we do know that TKIs, one school of thought is that it is treatment of metastatic disease at an early stage. So are you actually curing people by giving osimertinib after surgery, or are you just delaying the relapse in the patients who are going to relapse anyway? You can see that argument. There is an argument to follow with that, because if you look by stage, you see that the maximum benefit in DFS seems to be in the stage 3 patients, who are the ones that have the highest risk of relapse. So I think for certain health economies like the UK, it will be very difficult, I think, without overall survival for adjuvant osimertinib to be licensed or approved, used in the NHS. I think that will be very difficult. In other health economies, they'll make their own decisions. There was another trial at ASCO looking at adjuvant gefitinib, again in EGFR mutation positive patients, that did show overall survival data, and there was no difference in overall survival between chemotherapy or gefitinib. So a very interesting debate that's going to evolve over the next few years.